Heart failure, HF, or congestive heart failure, CHF, is a complex clinical condition where the heart cannot pump blood effectively due to structural or functional impairments. The primary cause is ischemic heart disease, though hypertension, valvular disorders, and myocarditis are also major contributors. HF is classified by left ventricular ejection fraction, F, and clinical staging, guiding diagnosis and management. Acute decompensation of chronic HF occurs due to fluid overload, arrhythmia, or medication noncompliance. Airway signs and symptoms. Increased frothy sputum may compromise airway clearance and pose a risk for aspiration. Persistent cough can threaten airway patency, especially during acute episodes. Some patients maintain no airway obstruction, though close monitoring is required. Obstructive sleep apnea, OSA, may coexist, further impairing airway patency and oxygenation. Breathing signs and symptoms, tachypnea, dyspnea, may only speak in short sentences. Orthopnea, worse when lying flat. Cough, often recumbent. Pulmonary crackles, may be absent early. Wheezing or frothy, pink-tinged sputum in severe cases. Circulation signs and symptoms, tachycardia, chest pain or pressure, hypotension, SBP 90 mm Hg with dizziness or renal dysfunction, diaphoresis, jugular venous distension, JVD, cool extremities, delayed capillary refill, pulsus alternans, alternating strong, weak pulse, irregular pulse with atrial fibrillation. Disability signs and symptoms, fatigue and exercise intolerance, dizziness or confusion, altered mental status, especially in advanced HF, abdominal discomfort or fullness. Exposed signs and symptoms, cachexia, muscle wasting in decompensated CHF, anxiety or restlessness, cool, clammy or cyanotic skin, possible digital clubbing, peripheral edema, common in most HF, anorexia and early satiety. Family and vitals signs and symptoms, tachycardia and tachypnea, hypertension or hypotension, depending on HF type severity, worsening dyspnea or edema, new or worsening fatigue. In congestive heart failure, oxygen supply is decreased due to a decreased stroke volume, which decreases cardiac output. Damage to the heart increases oxygen demand because hypertrophied and non-compliant tissue requires more oxygen to attempt to effectively contract, so it can produce sufficient cardiac output against the increased volume throughout the system. The result is oxygen demand will outweigh available oxygen supply, and end-organ perfusion is negatively impacted. Secondary assessment snapshot, focused assessment, cardiac, respiratory, renal, subjective assessment, LOTAR, OPQRST, diagnostics, troponins, BMP, electrolytes, GFR, creatinine, CBC, chest ray, bedside ultrasound, echocardiogram. Focused assessment, distress, pallor, diaphoresis, cyanosis, pulse rate, rhythm, quality, capillary refill. Look at chest for scars, pulsations, palpate, check legs for edema. Common ED meds, diuretics, nitrates, ACE and ARBs, vasodilators, beta blockers, inotropes. Thank you for watching our video.